Okay. Good afternoon, everyone. So I see it's exactly 2 o'clock South African time. Well, good afternoon, good morning, wherever you're listening in from. We are just waiting for one of the presenters that doesn't seem to have arrived just yet, but I think that we can get started just in order to save on time. So my name is Tracy Muwanga, and I'm going to be hosting the webinar today. And essentially, we are having this as a part of our initiative, the Cannabis Organization of the University of Pretoria, where we conduct, webinars such as this, and we also look into research evolving around cannabis. So, as you know, in South Africa, cannabis possession and use was decriminalized in 2018. And what that just meant was it was then legal to possess and to use cannabis in small amounts, but not legal to sell it. Okay. And to this day, it's also still not legal to sell it, but from 2018 until now, we were waiting for legislation, like formal national legislation to be passed. And we have that now as of, I think it was 2 months ago. We now have the Cannabis for Private Purposes Bill, which does allow for people in South Africa to use cannabis in small amounts and to possess it, to grow it in small amounts in private, so not in public and not around minors. And this is only applicable to adults, right? People over the age of 18. So with that in mind, we thought that it would be a good idea to have a webinar where we discuss with a few experts the mental health risks or potential benefits of using cannabis. So we are going to be discussing having this discussion with 3 people today. And the way that we will conduct today's session is I will introduce one of the presenters, and then they will give a short presentation, 15 minutes or less if possible, just to save on time. And then we'll move on to the next presenter and so on and so forth. Please remember to keep your microphones off, and you can turn on your videos if you'd like to, or you can keep them off, but microphones for now should be switched off. After all 3 presentations, then please feel free to maybe raise your hand, or you can speak through the microphone, and so on and so forth. Myself and Dr. Mark, who is also in the webinar with us today, will be monitoring the chat. So feel free to introduce yourselves if you'd like while we get started. And you can also put in your questions in the chat section, and hopefully we'll be able to get to them after all 3 presentations. And yeah, I hope that it's also all right. We will be recording this session today, so just to keep that in mind, and hopefully that's okay with everybody. I think that should be, yeah, I think that's everything. So just to remember to keep your microphones on mute. Questions in the chat. You can introduce yourselves as well. I see a few people have introduced themselves already. And yeah, and then so we will get, I think we can get started then. So I will ask also to be forgiven for butchering any names. I'm not South African, so I'm actually like terrible at saying names. So please forgive me and please correct me. I will start by introducing Mr. Isaac Mokgaola. He is a nursing lecturer at the Faculty of Health Sciences at Northwest University Mahikeng campus, specializing in mental health, adolescent substance use and abuse, and well-being, as well as primary mental health, as well as primary mental health care. So Mr. Isaac, if you wouldn't mind taking the floor. Thank you.
Thank you very much, Dr. Muwanga. Greetings to everyone. I'm going to try to share my screen. Yeah, I don't know. Please tell me if you are able to see the screen.
Not yet, no.
Okay.
Maybe in the meantime, you can put on your video as well so that we can all see who is going to be presenting, if you don't mind.
Okay. Yeah, let me switch on the video.
Okay, we can see a very beautiful background.
Okay. I'm trying to switch on the video for now. But
Okay.
I've switched on the video. I don't know if I'm.
I think you might have something blocking the camera.
Yeah.
But that's all right. We can probably resolve that at a later stage.
Yes.
Yeah, I think that maybe you could start the presentation in the meantime, and we can sort out the video a bit later. Wonderful. Yeah, we can see it now. Thank
Okay,
you.
thank you very much. Okay, I'm Isaac Mokgaola, as Dr. Muwanga has indicated, and I'm going to talk on cannabis and mental health. And this is the outline of our presentation. We are going to look at the background, which she already covered to some extent. And then we are going to look at the prevalence of cannabis use in South Africa, overview of cannabis, just a brief overview of what cannabis is, and then the health risks and health benefits of cannabis, and then we'll close by challenges that are related to medicinal use of cannabis. Dr. Muwanga has already indicated the legislation regarding cannabis, and I will just go to the contribution to the production of cannabis. According to the United Nations Office on Drug and Crime, Africa is the highest producer of cannabis worldwide, contributing 25%. And in Africa, South Africa is the highest producer, contributing 28%, and it contributes 7% to the global production of cannabis. And when we are looking at the prevalence of use of cannabis in South Africa particularly, you'll see that literature indicate that South Africa has the highest use of cannabis with 16.7% lifetime use reported. And then literature also indicates that majority of people who are using cannabis are males and adolescents. And it further indicates that adolescents use cannabis more than any other age group. And one study that reported on the statistics, national statistics in South Africa, but these statistics were from 2017. It indicated that in the age group of 15 to 29 years, 6.3 people reported a lifetime use of cannabis, and 3.3 reported that they are using cannabis on a daily basis. And when you are looking at the age group of 30 to 44, you can see a slight decrease of 5.2 in the people who reported lifetime, and the same percentage of 3.3 in the daily use. And another study reported that from 2022 to 2017, there was an increase of 16.3% during those years in the use of cannabis in South Africa. And it also reported that cannabis is mostly used in urban than in rural areas. Then generally, when we look at what cannabis is, we all know that it's a plant, and the most common species that are known is sativa and indica. And again, these two species are said to have high concentration of chemical molecules. And the chemical molecules that you can find in cannabis are cannabinoids, terpenoids, and others. And primarily, or the main concentrated chemicals are cannabinoids. And when we are looking at the cannabinoids, we have two types. The first one is cannabidiol, and it is associated with the health benefits or the therapeutic effects of cannabis, while we have delta-9 tetrahydrocannabinol, and it is associated with psychoactive effects of cannabis. And the use of cannabis can be related to culture, can be related to religion, and also recreational or leisure, and it is also used medically. Then, when we are looking at the health risks, it is a known fact that cannabis can cause addiction and it causes intoxication, and a person will experience withdrawal symptoms after taking cannabis. And then we have the cannabis use disorder, where is the dependence on cannabis and is also addiction on cannabis. Then literature also indicates that cannabis can lead to substance use disorders because people who are using cannabis usually use other substances. Then it also lead to different mental disorders such as psychotic disorders, personality disorders, anxiety, and other disorders like PTSD. And then physiologically, it is indicated that it can affect the respiratory system and make a person prone to respiratory tract infections. When we are looking at the benefits of cannabis, literature indicates there is a good evidence that cannabis is effective in treating epilepsy, and it can decrease the number of seizures related to epilepsy, and it also helps in the other conditions like Dravet syndromes and others. And there is limited evidence on, sorry for that, there is limited evidence on the effectiveness of cannabis on reducing other conditions or symptoms that are generally indicated in literature and indicated by different people when we are talking to them. It's said to reduce nausea in different conditions and in different therapies, like in chemotherapy. And it is said that it can increase appetite in people who are having conditions such as AIDS and such as anorexia nervosa. And it relieves pain in a lot of different conditions. And when it comes to mental disorders, there is conflicting reports in literature because anxiety disorders, dementia and schizophrenia and others are indicated as the conditions that cannabis can reduce the symptoms thereof. Yet when we are looking at other articles, literature, still you'll find others saying that cannabis itself can cause anxiety symptoms in a person. And physical conditions that are said, cannabis is said to be effective against is glaucoma and asthma. Now, we are going to look at the challenges that are related to medicinal cannabis use. And before we go into them, I just want to indicate this. We have most of the people are using cannabis as a plant. Then they are not using the products of whereby cannabis derivatives are used or singled out. Then when we look at the market, we also have the products, cannabis-related products that are only consisting of cannabidiol, and others are having THC. But when we are using a blend, you are taking both of these molecules as well as other molecules that are less in amount considered to them.
I'm sorry,
Then,
Mr. Isaac. We have 5 minutes left.
okay, yes, this should be the second last slide. And let me then just go to the last one. Then in conclusion, I would say that it is important as healthcare professionals to know that the legislation landscape now makes discussing cannabis with patients more complex, and it might be sensitive to those who are using it religiously or culturally. And there is a lot of misinformation about cannabis, and we have the responsibility to learn as much as possible about cannabis. And when we are advising patients to use cannabis or prescribing cannabis to them, we should first make sure that we do a thorough research on what we are going to advise the patient on. With that, I would like to thank you very much. Thank you.
Thank you so much for a wonderful presentation. It was very interesting to see the different benefits and health risks surrounding cannabis, as well as just general information. For instance, I didn't know that South Africa was has the highest use of cannabis on the continent. That was quite an interesting discovery for me as well. So thank you for that. I think that we can now move on to our next presenter, Mr. Werner Breedt. Again, my apologies for butchering names. So Mr. Werner is a researcher and advocate for non-ordinary states of consciousness, including music, media, psychosis, schizophrenia, and psychedelics. So he's currently supporting the development of the Southern Center for Indigenous Psychopharma, or SCIP for short, which researches psychedelic, entheogenic, and psychoactive plants, fungi, and animals local to Southern Africa to address a range of urgent mental health, neurological, and substance use disorders. So this also includes the application of psilocybin, my apologies, in psychedelic-assisted psychotherapy for the treatment of depression and substance use disorders. So thank you, Mr. Werner, for being with us today. And yeah, you can start your presentation when you're ready.
Thank you so much for having me, Dr. Muwanga, Dr. Gerhard, everybody at COUP. I also say hello and welcome to everyone watching at home and abroad, and also to some of my SCIP members. Although we are still a developing center, so we are still just a group and an initiative developing a center, we have tremendous overlapping interests in faculties and departments. So welcome and hello to Dr. Gary Stafford, as well as Sanela Matebela, and any others. Even our next speaker, Dr. Gerhard Grobler, is also participating in really wonderful and novel research. Because we are short for time, I say thank you to my compatriots, to Mr. Mokgaola, if I'm saying your name correctly, for the really good summary. because we are speaking across interests here. You will also see this contradictory information for the benefits and risk for certain disorders, for certain physical ailments. And so rather than speak only about the risks of legality, I'm interested to speak across that and speak about the consequences of illegality, which I think our first speaker has already shown us the consequences thereof. So I will be looking at potential treatments. Just to say welcome, I'm from a working group and initiative developing the Southern Center for Indigenous Psychopharma. We are excited to be working in this novel space, overlapping Western allopathic and traditional and indigenous healing methods to try to find the most novel treatments for mental health, neurological, and substance use disorders. There's a lot more to say about the development of the center, and we are so excited to be working alongside and with COUP members. There are interesting overlaps when it comes to plants, fungi, and biological materials that are psychoactive, entheogenic, and beyond. So what does it mean to have consequences of illegality? Whenever we have a drug being legalized, we ask, what are the risks? But there are certainly long-term risks for it having been illegal for so long. And our first speaker's data has shown this. The first thing that happens when a drug is illegal for long, and this is true not only for cannabis, but for alcohol in our prohibition era of America, that has taught us a great deal, concentration increases. Now, concentration increases obviously for many reasons, and one will be because it creates a greater profit. If something is dangerous to transport across borders and spaces, the higher the concentration, the better the outcome for the person selling it. And so as long as a drug remains illegal and in only a recreational environment, the concentrations of the active compounds in those spaces will increase, leading to all sorts of risks for psychosis and other personality-related disorders, which we may hear about in our next session or webinar provider. The illegal market is, of course, sustained. Regardless of the war on drugs having been taking place for years and years, drugs have unfortunately won, and they will continue to do so. No matter the control put in place for supply or demand, the black market continues to occur. And as a result, access is unregulated and limited to the worst population at highest risk, young adolescents and youth, and access is not provided for those who have serious ailments and serious treatments needed. So this is the funny and tragic outcome of making a drug illegal, is that the people who need it most, geriatric populations and vulnerable populations with serious mental and physical ailments, have no access to a street or drug market, while young individuals, adolescents, teenage people, and people taken up in all sorts of spaces, including gang culture created by these illegal markets, have access. So when we look at the numbers in terms of ages of use for cannabis, it might not be the natural nature of cannabis use. It might be our societal inputs here, and having made this drug illegal and regulating only in the black market has created access for the young, which increases risk, and a lack of access for people who need real medication. I'm just moving this across here in case we want to see all of our text. So now we're looking at examples of this. THC potency in dried cannabis has increased from an average of 3% in the 80s to around 15% today. This is from stats from the government of Canada. And some strains have an average as high as 30%. Now, you may hear about THC and CBD, cannabidiol, and tetrahydrocannabinol, and they play a part not only in isolation, but in hybridization. They are important. Whole plant studies have shown that there is a benefit having a balance of each. And that's also why we see some contraindicative research coming out for disorders such as schizophrenia, for example. We know that an increased activation of THC can lead to psychotic drug-induced psychosis or schizophrenias, or can at least exacerbate them. But we also have been seeing that CBD and cannabidiol can play a reducing or a reductive effect for psychotic symptoms, not only in schizophrenia patients, but in those Parkinson patients who have been taking L-DOPA. So it is a fascinating play between these two spaces, THC and CBD, where all of the novel research is sort of butting heads. And all of that being said, we have seen a reduction in CBD and an increase in THC because of our higher concentrations in our black and illegal markets. Now, there are many, many interesting studies that will show how shall we say, a tremendous cannabis use across the world and across provinces. But as states legalized, it doesn't seem that there is an increase in adolescent use. And so I want to say and suggest that more research is needed in this area. But as cannabis and other drugs become legalized, more regulation is in play. And it means that the black markets is stifled to some extent. More education and harm reduction can be done. And so we saw in comparisons here between a state, for example, Washington, which had legalized marijuana use, and other states which had not, there was no significant increase in adolescent use. There was a continued downtrend of adolescent use. That's not to say that that is because of legalization. There seems to be a global downtrend of adolescent using cannabis, at least during these years of study. But very interesting to note that when we legalize, we sometimes, it suggests, actually reduce access for adolescents and increase access for people who really need it. Now, this is a good example, and I hope that I'll be able to share both my sound and my, there we go, and my video. I've saved a little time. I'm speaking fast to show you anecdotal examples and then research and theory that supports this fact. I also saw some people in the chat who have already provided information that I'll speak to later, and I'd love to hear from your personal experiences with marijuana and cannabis. Let's see if our video works properly. I'm going to wait 1 second to see if the video will play. If not, then I'll pause and we'll continue. Sometimes when we embed a video into a PowerPoint, it gives us more trouble than it offers solutions.
Hi, Larry. How are you?
Come in, come in.
Let's see. How you feeling?
It's been a bit of a rough week.
Really? And the best way to take it is put it under your tongue and rub it in your cheek. Don't do too much. You're going to be asleep all afternoon. You know what you should do?
No.
Don't try to communicate. Just relax. See what happens.
We know from animal experiments that the endogenous cannabinoid system is very important in regulating motor activity, that very type of activity that is impaired in Parkinson's disease. From animal experiments, we also know that boosting certain branches of the endocannabinoid system is helpful in relieving symptoms of Parkinson's. Finally, from anecdotal information, we know that certain patients who smoke marijuana experience relief of their symptoms.
I think you're calmed down.
So quickly.
Isn't that amazing?
He used just a single drop, and his hands afterwards were rock steady, and the dyskinesia left.
It was coming back.
It works most of the time.
In fact, it's...
I paused there just to show the incredible effect for the right population, the right dose, the right balance of CBD and THC can have on a patient's well-being. And in preparing for this presentation, it was impossible for me to separate mental and physical health. Can you imagine the benefit of someone's mental health if they're able to function just slightly more stably, just to have a smooth function? And I've just found 3 examples because of our short time in my preparation for this presentation to show you today. We have access for the wrong populations, and we have a limited amount of access and research for the right populations. Tardive dyskinesia not only plays out in Parkinson's, but also in schizophrenia and for outcomes for many other drugs. And so it is very, very helpful for research to push into these quick wins. Here's an example that we see inside of our theory. Not only anecdotally, cannabidiol prevents motor and cognitive impairments induced by risperidone in rats. And now we might see some benefit for, shall we say, very difficult side effects of drugs, antipsychotics specifically here, and how cannabidiol might actually play a huge role. Just for the speed of brevity, I'm moving through these articles fast, but I have provided these articles that I'm showing to you now to Dr. Muwanga, and you are welcome to receive them after the fact to read through them in detail. And I also emphasize there are difficulties in creating cause and effect relations here. Sometimes the research is underpowered in sample. Sometimes there's a self-reporting bias here. So we need more research within tertiary institutions, just like the university now, to actually pursue clinical trials, feasibility studies for a range of these quick wins in cannabis research. 1 second. Here's a second anecdotal example, and I will follow with some theoretical examples and evidence.
My daughter is special. She's a young girl with disabilities, born with refractory epilepsy, which caused a delay in her neurological development and convulsions that are very difficult to control. Luna has taken around a dozen kinds of anticonvulsants, and nothing has worked, and she isn't a good candidate for stimulating drugs or something else to control the seizures, because she has a very weak immune system. We've tried all sorts of treatments, none worked. Luna had seizures every day until she was 11, in the morning and when she went to bed. I saw the light at the end of the tunnel when they suggested I give her medical marijuana. I saw it as an alternative, and it's the only solution we found so far. Since January 9th this year, after 11 years of convulsions, Luna started taking medical marijuana, and on the 9th day, the seizures stopped, like by miracle.
We are very glad to see examples like these, but as long as they remain anecdotal and outside of serious research endeavors, they will remain to be examples and not evidence. We do see a tremendous amount of literature for the treatment of epilepsy, and I noticed one of our viewers in the chat speak about this early. There is a vast amount of literature when it comes to how cannabis or marijuana can help to reduce symptoms for epilepsy. But we will notice that these trials seem to be underpowered, many times samples less than 15. When we see an increased sample size of more than 100, there is a significant reduction in seizure frequency, epilepsy frequency. So there is a benefit for cannabis and marijuana immediately to vulnerable communities inside of pathologies related to neurology, but they do not have access to the illegal or black markets, or they cannot confirm what medicine and what product they are actually taking at the moment. Here's another example of protective effects of cannabidiol. Let me move this for us. Against seizures and neuronal death in a rat model of mesial temporal lobe epilepsy. This is just an example of how epilepsy and epileptic disorders have shown not only in human anecdotal examples, but in rat and in human models, how epilepsy can be treated or reduced tremendously. It is interesting to see that not all epilepsy cases have this mass reduction that we've seen in these anecdotal clips. The same for our tardive dyskinesia. What is the difference? Is it the difference in balance between THC and CBD? Is it the way that it's being administered? These things need to be controlled in larger trials. A third example that we've already mentioned and seen in Mr. Mokgaola's presentation is late-stage and palliative care. And it is so wonderful to see that if we are able to treat vomiting and nausea, sleep issues, diet issues, self-regulation issues with one drug, why are we not seeing more research in this area? If funding is available, if we're here at the right place at the right time, what can we do for cancer patients late stage? This is an example of the use of THC, now moving from cannabidiol to THC with an increase in survival time in palliative cancer patients. And this was a very large study, a cohort of more than 7,000 persons, looking at survival rates of between 7 and 100 days. In both cohorts, we saw an increase in their survival days, more than 7, but interesting to note that dose is important. Dose is significant. We saw here an association with a significant increase in survival time in our palliative patients, our cancer patients, but this was specifically for THC larger than 4.7 milligrams per day. So how can we help patients and people who do not have access currently to the right medications at the right doses if we do not move ahead with strong research to prove these anecdotal and these first wins? Thank you so much for the time. I've saved some minutes, hopefully, so that we can chat along the way. I appreciate all the opportunities to share this.
Thank you, Mr. Werner. You actually were spot on with the time. Thank you so much for that. So yeah, that was an amazing presentation. I really enjoyed the highlights that you brought to, I mean, the fact that we have this illegal market that's not being regulated, and, you know, access to cannabis is also not being regulated. And yeah, definitely agree with you when you say that more research is needed, especially for the people that actually need this drug for medical purposes. So I think we can move forward to our last presenter of the day, Mr. Gerhard Grobler. is the principal psychiatrist and head of the psychiatry clinic unit at Steve Biko Academic Hospital and has a joint appointment with the Gauteng provincial government and the University of Pretoria. So his position requires both clinical service delivery and pre and postgraduate student training. He heads one of the two firms of the unit with at least one consultant round and a multidisciplinary round per week. So thank you so much, Prof. Grobler, for being here today. And you may begin when you are ready. Thank you.
Thank you very much. And first of all, to COUP for your kind invitation to speak. It's also nice to see colleagues also from SCIP here. I just want to check, can you hear me clearly?
Yes, we can hear you perfectly.
Thank you. Well, I'm also going to share my screen. I hope that that runs, and stop my video, as I have a face more suited for radio than TV. But thanks again for the invitation. My topic is to speak about psychiatric consequences of cannabis use, and I think I should have actually changed the topic to potential psychiatric consequences. But before we get to those, let me just do there we go. So I want to do my introduction by way of this meme from The Princess Bride. Some of you who are familiar with the story would know that this is how Inigo Montoya introduces himself to the six-fingered man, and I want to use the same kind of model. So bearing that in mind, wanting to say hello, my name is Gerhard Grobler. As you've heard, I'm a psychiatrist in clinical practice and also academic at the Steve Biko Academic Hospital. And just to manage your expectations for what I'm going to do is I'm going to be the break in this session, because I think there's a lot of positive talk that comes out, and the benefits of cannabis and cannabis use, which is undoubtedly there, but there are also risks and consequences. And as a psychiatrist, as a medical practitioner, I want to just highlight those, particularly in the mental health concerns. Here are my declarations. My affiliations I've already mentioned. I have no particular conflict of interest other than also, in the sake of transparency, say that I'm part of the SCIP work group. And so I have interest there. But other than that, there are no conflicts of interest in this presentation. And also the role of generative AI in this presentation. Generative AI assisted in the literature review, but not in the presentation that I made, and all the mistakes there are my own. So undoubtedly, cannabis plays, at least in a certain part of our communities, a very important role. We've already alluded to religious practices and cultural practices that for a long time went unrecognized. There's certainly a lot of stigma around the use of cannabis, and just the names that you can see, most of those are from America. There's no doubt that cannabis plays an important role, and that, as many other substances, not everybody that uses cannabis on occasion or even regularly develop health or mental health consequences. But there is a significant group of who then become patients of mine that do develop psychiatric consequences. And there are basically two large groups that I'm going to refer to. The first is cannabis use disorder. The first speaker referred to cannabis addictions. We don't like to talk about addiction anymore. We refer to it in the DSM-5 terms as cannabis use disorder, which is a particular consequence of cannabis use, and then cannabis-induced disorders, which I will go through in the next few slides. So let's turn to cannabis use disorder. And there are three that I'm going to talk about. The first is cannabis use disorder per se, then cannabis intoxication, and cannabis withdrawal. Now, cannabis use disorder, which used to be called cannabis addiction, later caused cannabis abuse, now called cannabis use disorder, refers to a problematic pattern of cannabis use that leads to clinically significant problems. And there is a whole list of criteria that defines cannabis use disorder. Now, these are quite generic symptoms. You see this very much the same in alcohol use disorder, cocaine use disorder, sedative hypnotic use disorder, opioid use disorder, and so forth. But it essentially comes down to the prolonged use of cannabis, a sense of loss of control, that people try to cut down on the use of cannabis and are unsuccessful, a great deal of time spent on activities necessary to obtain, to use, or to recover from the use of cannabis, cravings, that there's a sense of need to use cannabis. Also, the recurrent or continued use of cannabis despite failure in role fulfillment. And then what's very interesting for me is, and this is true of all the substance use disorders, when there's a recurrent or continuous use of substances where it's physically hazardous, so driving under the influence of cannabis, if it causes motor dysfunction. So I was very interested in Werner's presentation to see that cannabis actually enhances motor function. But there are studies that indicates that cannabis actually leads to this uncoordination of motor function, so that driving under the influence of cannabis is risky, or giving up social or recreational or even work activities in favor of using cannabis, and then continuing to use cannabis despite having a physical or psychological problem or a relational problem. So even if you smoke cannabis and your partner doesn't want you to smoke, but you continue to smoke, that's one of the defining elements of a cannabis use disorder. Cannabis intoxication refers to the use of cannabis that leads to then certain symptoms. And there are only 4 described in the DSM-4. The one is conjunctival injection, so red eyes, an increase in appetite, and that's where we used the side effect in, for example, HIV treatment, cachexia of cancer, and so forth, dry mouth, and tachycardia. So you can already see people with cardiovascular disease, cannabis intoxication is not really in their favor. And then cannabis withdrawal describes a particular syndrome that develops after the cessation of cannabis that were both heavy and prolonged. And there are very typical signs that happen. You need at least 3 of a list of 7, so almost half of those symptoms. And those would be things like irritability or aggression, nervousness or anxiety. We'll talk about that a little bit more. Sleep difficulties, particularly insomnia. We'll talk about that a little bit more. A decrease in appetite or weight loss, which is a bit strange considering that it increases appetite during intoxication. Then restlessness, a depressed mood, and then physical symptoms such as chills, headaches, abdominal pain, nausea, fever, shakiness. Okay, so those are our cannabis use disorders. The cannabis-induced disorders, cannabis-induced disorders, there are only 4 that I want to highlight, or there's only 4 that we're going to talk about. The first is cannabis-induced psychotic disorder. Now, that is the most common feature of cannabis use. And why some people develop CIPD and why other people don't, I'll return to a little bit later in the conversation. But this occurs during intoxication, and it affects mostly adolescents and young adults, and that is typically the time that people start experimenting with cannabis. And this is what we see. They come into our unit or through the Tshwane district unit with intoxication followed by a period of psychotic features. Now, regular users have a 2 to 4 times higher risk of developing cannabis-induced psychotic disorder. But if you have heavy users, and the literature is not clear exactly what heavy users means, there's a 6 times higher risk. So you can see that there's a marked increased risk of psychosis in vulnerable patients, of vulnerable people, when they take cannabis. And the whole issue around does cannabis cause schizophrenia is a hot topic, or it's up for debate. It's a moot point. Now, the current thinking is that the use of cannabis does not lead to schizophrenia per se. But if you are vulnerable to developing schizophrenia, and on top of that you use cannabis, you then unmask the schizophrenia, and you start that process with a prolonged illness that is then activated. And why that's relevant, I will come back to at the end of my talk. The Swedish cohort study of a couple of years ago, about 20 years ago, made that point very clearly. So you can smoke cannabis if you don't have a family history of schizophrenia or other psychotic mental illnesses. You probably don't have the risk factors. Nothing happens to you. But if you have the vulnerability genes and you smoke, you then develop schizophrenia. We have a lot of our patients who are diagnosed with schizophrenia and then continue to smoke cannabis. They use a whole bunch of other substances as well, but let's for today focus on cannabis. So if you do happen to suffer from schizophrenia, it's not a good idea to continue smoking cannabis because it leads to an earlier onset of symptoms. I've already alluded to that. Schizophrenia typically starts in our late adolescence, young adulthood, somewhere between the age of 15 to 25 is the usual onset. And not only does it activate the illness earlier, so it means your outcome over your lifetime is worse, but you also have exacerbation of symptoms. And we certainly see that in my clinical practice, that patients would be stabilized on their medicines. They very often stop taking their medicine and they start smoking cannabis, and they come back with a relapse of symptoms and, in fact, exacerbation of their symptoms. It causes more severe positive and negative symptoms. Now, for those of you who are not psychiatrists or medically trained people, positive symptoms refer to hallucinations, delusions, disorganized behavior, and that's typically what gets people to the hospital. If you start kicking the dog and breaking windows, swearing at people and taking off your clothes and running the street, then you get to my unit. But also negative symptoms, and the negative symptoms are the so-called deficit symptoms. So those are social withdrawal, blunting of affect. So these patients have a mask-like affect. They don't show their emotions on their faces. They're more withdrawn. They've got lack of drive. And that is actually what disables patients. So the positive symptoms get you to the hospital, but the negative symptoms takes you out of your work, out of your relationships, out of your community, and you withdraw. And it becomes this vicious cycle where people then want to self-soothe their pain with the use of cannabis and other substances. There is evidence of higher relapse rates in patients with schizophrenia who continue to smoke cannabis, and they also lead to longer hospitalizations. I'm going to speed up a little bit just in the interest of time and so that we can have time for discussion. We have cannabis-induced anxiety disorders. This also happens in intoxication. There's a higher risk of depressive symptoms and anxiety symptoms, but less evidence than we have for psychosis. It has a negative impact on cognitive function, including executive function. Now, executive function is the thing that you need in order to make good decisions. So planning and sequencing your behaviors. And if that becomes impacted by substances, you can see how very easily that leads into a sustained substance use disorder, or if you want to use the term addiction. So the more you smoke cannabis, the more your executive functions, your decision making, your memory for the bad experiences you've had become impaired, and that leads to being more vulnerable to using the substance again, and it becomes this negative snowball that just escalates. There's evidence of increase in suicide ideation, and although we don't recognize in the DSM-5 a cannabis-induced mood disorder, there's certainly evidence of exacerbation in symptoms of patients with bipolar disorder. And so generally, we don't want people with bipolar disorder to use a variety of substances, including cannabis, but also alcohol, psilocybin, cocaine, definitely not cocaine, and a whole bunch of other substances. And for the purpose of this talk, we focus on cannabis. Cannabis-induced sleep disorder. So the question is, does weed help for sleep? The short answer, unfortunately, is no. And I know I have a lot of patients who say, I smoke cannabis, it makes me feel calm, helps me to sleep. That's not what the evidence says. So one of the symptoms of cannabis withdrawal is insomnia. And so typically patients who use cannabis frequently, who are heavy users, what happens is that they have a sense, they withdraw from the cannabis, it causes insomnia, they smoke weed, they become intoxicated, and then they think they sleep better because it actually treats the withdrawal symptoms. Cannabis also can then cause a whole variety of sleep-related disturbances, including like restless leg syndrome and dreams, which also disrupt people's sleep. And the last one I want to highlight is cannabis-induced delirium. Now, for those of you, again, not familiar with delirium, delirium is sometimes called acute confusional state or acute brain failure. And that is where a person develops, I beg your pardon, where a person develops, you can see there on the slide, it talks about acute onset. So it's a very acute syndrome that develops, altered level of consciousness. So the person is in and out of consciousness. They can't sustain their attention. Their wake-sleep cycle is disorganized. You have sometimes what is called sundowning. So they're asleep during the day, they're awake at night and restless with disorganized thinking and disorganized behavior. You'll see they talk about psychomotor agitation, perceptual disturbances, the hallucinations, and then memory impairment as well. And I'm very close to the end. This is my last slide. And this is the genetic lottery. Now, what I want to illustrate here is the interplay between environment, culture, and our genetic component. And there's a lot of work being done on the interplay between culture and nature. And then if you put on top of that cannabis or other psychoactive substances, you could have problems. So I referred earlier in my talk to genetic vulnerability for cannabis. If you carry, schizophrenia, if you carry the schizophrenia genes because of your ancestry, and you put cannabis on top of that, you are going to start a process that's going to lead to an enduring mental illness. And what young people don't understand or what they don't realize is that they don't know what their genes are. So they will say, but all my friends smoke cannabis, there's no problem, why can't I smoke cannabis? Not knowing that lurking like a crocodile under the water, they have the genetic predisposition for a psychotic or a mood or anxiety disorder. And they start pushing that wheel until it develops then into a runaway train. So the last comment I want to make, there was a study done in America that looked at people who were admitted for substance-induced psychotic disorder, in this case cannabis-induced psychotic disorder, treated those patients and then followed them up for a year. And what they found was, even in those guys who don't smoke cannabis, the following year, 60% of them developed schizophrenia. So if you smoke cannabis and you have a psychotic episode, you have an increased risk of further psychotic episodes a year later, whether or not you continue to smoke cannabis. Obviously, if you continue to smoke cannabis, your risk is increased, and that then leads to an enduring psychiatric disorder. I'm going to end here. Thank you for your participation, and I look forward to our discussion. And back to you, Madam Chair.
Thank you so much, Prof. Grobler. I think that the information that you shared was extremely vital, especially considering that that you're a psychiatrist and have worked in this field as well for a bit of time. It was particularly interesting to see the negative effects of cannabis use, because oftentimes people don't think about that, because when you have when you think that there's a benefit from it, it's easy to forget about the risks and how cannabis can be linked to schizophrenia and psychosis, and also just the possibility of having a higher relapse. I thought that was quite something. So for the last, we have 20 minutes left of the webinar today. So for those 20 minutes, I would like to see if we can engage with the people in the chat. I see that there have been a few questions. So I think perhaps the best way to do this would be to look through the questions, and then perhaps any of the speakers who feel they might be able to answer can raise their hand, and then we can continue from there. And yeah, and if you have a question that you don't want to perhaps type in the chat, you can raise your hand, and then we can see if we can give you the floor for a little bit, and you can also pose your question in that way. So I think the first question that I saw in the chat was something to do with the prevalence of cannabis in South Africa. Our first speaker mentioned how the cannabis use is more prevalent in South Africa. than in the rest of Africa. And I think the question was whether, or what was the reason for that? Is it because of the social demographics, or are there any reasons, any speculations that perhaps anybody might be able to answer? I think it was Mr. Isaac who spoke on this. I don't know if you perhaps would be able to answer that question.
Thank you. Yeah, I do not find any particular reason for why it is South Africa is the highest. I don't know if Prof and Mr. can help.
Don't know if maybe either of our presenters might be able to shed some light on this. It could perhaps also be a case of more research needing to be conducted. So, I mean, cannabis was only legalized quite recently, so we're probably only going to start to see a bit more information as time goes on. I would also just like to point out that my colleague, Dr. Mark, has posted a few articles from Mr. Werner's presentation in the chat section. So please feel free to go through the chat and have a look at the articles that Dr. Mark has posted there. So, okay, now,
Tracy,
yes?
if I could perhaps just comment on why the highest use. I think one of the reasons, this is not really my field of expertise. I'm not a criminologist or a sociologist, but just from my clinical experience is that cannabis, as opposed to some of the other substances, are much more freely available and a lot cheaper. So in order to access, cocaine or other type of use, I'm very sorry for the interruption. It's quite difficult to do, and it's quite expensive. So there is a barrier to entry there. Cannabis is fairly cheap. It's fairly easy to produce, and it's much more accessible, even when it was illegal. Very much the same as alcohol, although alcohol, I think, is also expensive. And so that's why I think we see a lot of cannabis use in our communities, and linked to that then cultural factors and religious factors. And I think that is probably answer to that question.
Yes, that actually makes a lot of sense because, yes, truth be told, even before the decriminalization of cannabis use and possession, there was easy access, I suppose, to the plant even beforehand. So that does make, yeah, I think that would account for a lot of the reasons as to why it's used a lot more here. And actually, if I were to also maybe jump in a little bit on that, the reason why cannabis was decriminalized was because of a court case by a gentleman called Prince, who was a Rastafarian. So cannabis was decriminalized based on religious reasons. So I imagine religion would probably also be part of the reason as to why it's more accessible here. We have more individuals probably that will use it for cultural reasons, religious reasons, and so on and so forth. So I think the next question that I see here, I'm not sure if any of the speakers will be able to answer this. So it's, you mentioned earlier that the law permits private cannabis use for adults from the age of 18. However, with the increasing number of dispensaries opening across South Africa, I'm curious about the business licensing process. Is there a gray area or specific legal framework that allows these dispensaries to operate legally? So I'm not sure if anybody would be able to respond to that, if any of the presenters would have more information on the licensing process with regards to the dispensaries in South Africa.
I might be wrong, Dr. Tracy, but I think there was an answer in the chat that gave really good detail on this. I'm just going to slide through to see if there was one provided.
Oh, please do. I do see someone named Etienne Fansal, researcher and consultant specializing in cannabis policy. He states that there's no official pathway that exists to trade in adult use or medicinal cannabis, although national legislation is currently being promulgated to facilitate commercial activities. Okay, I think that's great answer. Okay.
Tracy?
Oh, yes, sorry, Prof.
I see a comment here. I see Mark shared a paper called "Has Cannabis Use Amongst Youth Increased After Changes in Legal Status?" I haven't read that paper, and I'm not going to do so quickly, but I could just comment. A number of years ago, I attended a congress in the US, and it was very shortly after the decriminalization of cannabis in one of the states in America. And so that was the introduction of medical marijuana in this particular state. And the idea was to make it accessible for people with cancer and HIV and chronic pain. And as Werner indicated in his presentation, we would expect the elderly population and so forth. And what they found was a fourfold increase in the use in the 18 to 24 year category. So it was very clear that, although it's intended as medicinal use, it's being used by young people. And you can see that as a form of diversion, of cannabis diversion. But that was the American experience. And I'd be interested to read the paper that Mark posted. I'll do so, but obviously not for the purpose of this discussion.
Oh, no, that is very interesting, actually. Yes, no, thank you for pointing that out. I think that also just bringing, just highlighting the fact that there are some articles as well in the chat. But yes, it'd be interesting to see what the South African experience would be with regard to that, for sure. Okay. I see two other questions here from Eben, my apologies if I've mispronounced your name. So Eben has two questions. With regard to usage for disorders such as Parkinson's, how long does it take for symptoms to return? Has any studies been done on the metabolism of the cannabis to prolong the beneficial effects? I wonder if perhaps that's for Mr. Werner.
I'm happy to slide in here, and I want to say thank you for the great questions, everybody, especially the questions here, Eben. I want to say that, have you heard the conflicting evidence whenever we're speaking about cannabis? Sometimes we're speaking about benefits for reduction in anxiety, and sometimes it increases anxiety. Sometimes we're speaking about helping with sleep, and sometimes it's creating insomnia. So you're going to find different answers in the literature. Have a look at the epilepsy and have a look at the dyskinesia articles that were shared now in the chat, and they will give you a longer answer when it comes to the amount needed, so the dose amount needed, and the tail off or the reduction of symptoms. But I find cannabis to be an interesting substance because of the complexity of its uptake. Not only are you going to see I think within 2 minutes of smoking, for example, that's the maximum high that you will feel, but it's taken up into the fats. And because it's taken up into the fats, it means that withdrawal rates are made more complex. And other than withdrawal rates being made more complex, the use can stack over time. So it is a fascinating and complex issue that you'll have to dig into the literature that I've shared with to get a good answer.
Thank you, Mr. Werner. I see Prof. Grobler, you have your hand raised.
Yes, I want to add two things to what Werner just said. The one is that and I've actually made a comment on the chat line to the exact point that he made. This is not strange in clinical medicine, that there are conflicting evidence and that there are controversies. In most of our allopathic treatments, if you're busy with clinical research, this is what you would find. There are side effects, there are unwanted effects that come to the fore in some patients, but not in other patients. So this is very standard, and I think, in fact, it's to be expected. I think if we had only positive or only negative effects, then we're probably busy with the wrong thing, and we're looking at the wrong metrics. So I think that it is a complex drug. It has cannabis, raw cannabis in itself has multiple psychoactive and otherly active components, which has a multitude of effects. The second thing I wanted to mention is the fat solubility of cannabis. And so, particularly in psychiatry, that is something that gives us gray hairs, because the brain consists, there's a large component of that has to do with lipid metabolism. And so any substance that is lipophilic also goes to the brain. So that's number one. And number two, what he alludes to is if you are a regular user of cannabis and a heavy user of cannabis, what happens is it gets taken up into your fat cells and it gets stored in your fat, and then it slowly dissipates over time. So if you regularly use cannabis and we test you, it can stay in your system for up to 30 days after you discontinue. So we regularly test our patient when they come in, and they will tell me, no, I've stopped smoking cannabis. But when we test them, they test positive because of the fat stores. And so, you can argue for a low-grade chronic intoxication in people who smoke the whole time, because it never leaves their body. It's not like alcohol. You drink and 2 or 3 hours later, it's out of your system. Cannabis tends to stay, particularly in prolonged use. That's not to say if you smoke a joint now and again on occasion, that's going to happen. But regular use, you're going to fill up your fat stores, and you're going to have a slow release of cannabis over an extended period.
Okay, no, that actually that makes a lot of sense, and it's very interesting to know, because I was myself curious as to how long cannabis can stay in your system even after you stop using it. So it's interesting to know that it stays within the fat deposits. And can I ask, I think that this also kind of leads to one of the other questions that I saw. Would there be a difference between the smoking of cannabis and maybe if you drink it in a tea or edibles?
If I can first say that edible marijuana and smokable marijuana have much variation in effect because it passes through the liver. It becomes a lot more psychoactive. And again, because of the societal implications of eating versus smoking, you'll find many people who want to try marijuana first will say, I'll first try to eat something before I smoke, to terrible, terrible consequences. It lasts longer. It's more psychoactive when it's edible. So there are these psychological and linguistic relations to how marijuana is taken, what is healthier, what is safer. I will say anytime you increase heat on a substance, it's going to affect it. So for example, if you decarboxylate marijuana at a certain temperature in the oven or at a heat, you are activating the compounds. If you go beyond that, you're combusting them and then losing value. So if you are putting something into a tea and heating it compared to inside of an oven space and decarboxylating or simply combusting or smoking, it's going to have an effect on what is activated for use and what is combusted and not available.
Okay, that makes a lot of sense. Thank you so much, Mr. Werner. I think Eben had one more question in the chat. What are the risks for the use of THC or CBD on the impact of neuroplasticity in developing brains, not including the risk of developing schizophrenia? How can it be determined if an individual's brain is developed enough to not have long-term cognitive development impairments? I think this is actually a really good question, just to sort of bring, to highlight perhaps the reasons why it would be better or worse if you're younger or older. I'm not sure if maybe one of the presenters would be able to shed some light on this.
I'm currently sitting quietly because I feel that a professional like Prof. Grobler has seen a great amount of experience for this, so he might be able to say more than I will. But I will say that it's about brain development. We forget that we've got such big heads as humans, and we come out of the womb early. We are not developed. And so it means that our brains can develop up until the age of 25, It's still debatable whether it's 22, 23, 24, 25 years old. And so any substance which you take in before the age of 25 is going to have a long-term impact on your permanent brain functioning going ahead. It doesn't, that's not to say whether it's good or bad, the change itself, but it's going to make a permanent change. And we've seen people who take psychedelics and people who take a lot of cannabis in their teenage years, they may have a high exacerbation of anxiety and personality-related disorders in their early 20s. I also really enjoyed some research that was shared actually in our COUP meetings by Prof. Grobler, looking at the development of personality disorders, and that a lot of disorders, they might come out or be noticed or diagnosed in the 20s or in the late teens, but they are developing already prodromally from age 13, 14, 15, So it's about the timing of use and understanding that your brain is not developed fully. It's being developed in the environment, and the environmental impacts will have a permanent effect on your brain. So that also is to say, if you swim in the ocean, that'll have a permanent effect on your brain for the better. So permanent effects are not bad, but what you do every day until you're 25 is going to stay with you. Thereafter, I think there's a more complex debate about if it has a permanent effect. Lots of neuropathy is certainly possible, but we also see neurogenesis in some conflicting studies.
Thank you. Thank you. That does make a lot of sense. Prof. Grobler, I see you've turned your camera on. Did you want to add on?
I fully agree with Werner's points there. I think that's absolutely right. You know, up to 25, the brain is vulnerable for all matters of impact, and particularly if you don't know what your genetic load is, how the cannabis might affect you. You know, one has to be very mindful and careful. It's one thing to say, well, it will have a beneficial effect. But if it has a negative effect, and those are lasting consequences, it's going to put your life trajectory on a track that you might not want.
Okay, now that's very good to keep in mind. So perhaps maybe if you're below the age of 25, I would be cautious with your use of marijuana. So there are some questions in the chat that have been answered. So I'm going to try to stick to the ones that don't appear to have been tackled with. I see there's a question here about hemp. So from Nomfuzo, hemp is said to be safer than cannabis for users. Does this mean hemp can be used in huge amounts or increased frequency and still be harmless? So I think here we're just trying to see if if there's a big difference between using hemp and cannabis.
Well, if I can just say, I'm not an expert on hemp, but I believe hemp to be exactly the same plant as marijuana, but defined as such because of the low amount of THC. Some studies say 0.3% THC. Some people speak about 0.1%. And the government recently made a certain decision about hemp, allowing for large-scale growth. So when you say use of hemp, I'm not sure what you mean. When I think of hemp, I think of rope and textiles more than medicinal use, but it would be curious to hear what you meant there.
Okay, no, that does make sense. I also think of hair products when I see hemp, because again, it's because of the THC. I think I read somewhere that hemp doesn't have as much, or if any, THC, or at least not enough to give you that
Just
high.
a low amount.
Yeah, it's a very low amount. So yeah, so I guess I don't know. We would have to then see if that would have a big difference with regard to whether you can use it in big amounts or small amounts, and so on and so forth. I think it's perhaps used for other reasons as a side to medicinal purposes. Okay, so I am just trying to see if there are any more questions. And oh, I see someone has mentioned a Netflix documentary. That would be interesting to look into. All right, there's a question from Harmony. Is SAPHRA the only organization that issues out license for cannabis practice? Oh, I see Etienne did answer that question. Yes, they are. And okay, I think we might be nearing the end of our question and answers. I don't know if there are any. Oh, yes, okay. I see a question here from Sean. Is there any research suggesting that cannabis helps in alleviating symptoms of vertigo? Okay, that is actually quite interesting. Not too sure if any of the presenters might be able to shed some light on that.
Perhaps I can go first. The short answer is not to my knowledge. I'm not aware of it. I'm not primarily a neurologist, so but I've not read anything around cannabis and vertigo. Maybe Werner knows.
No, I was about to give the same answer. I have not heard such, but just from my estimate, I imagine that it would not be a benefit if I had to anecdotally guess for vertigo. Anything related to, I'm not sure vertigo is really related to brain function or inner ear, but I would not think that cannabis would be an immediate treatment for that. However, I'm not sure about the literature.
Okay. Yes, it's quite a specific question, I must say, but it would be interesting to do a bit of research in that and just see what the answers to that could be.
I'm sure that if you were a sailor, it would reduce your seasickness, but I'm not sure if seasickness and it.
I'll keep that in mind if I ever go on a cruise. Thank you, Werner. All right, so I see we only have about a minute left until the end of our webinar, so I'll take this opportunity to just say thank you again to all the presenters that gave their time to be here today. It's been a wonderful session. Perhaps you can all just turn on your cameras very briefly so that we can just all see you and be able to give our thanks and to say goodbye. Thank you so much, everybody, for being here today. And do check out our, I think on the invitation, you should see that there was a links to our website, our Instagram page, our LinkedIn page as well. And yes, it would be wonderful to continue the conversations. If you would like to get in touch with me directly, I think you should have my email address should be on one of the invitations. You're more than welcome to get in touch with me. And we will also try to make the recording of this session available on the web, on our website. So thank you everyone for being here today, and I look forward to having more